Hi, so this is my respiratory video. Prior to proceeding with the video, I would like to ask for permission to record and upload this video as unlisted for my professor to view and grade. Do I have your consent?
Yes.
Awesome. My name is Renika. I am a FNP student and I will be doing a respiratory assessment on you today. I'm going to go ahead and wash my hands, put gloves on. So we're going to start off by doing the thorax lung inspection. So while our patient's sitting, I'm going to have a look at the chest. The contour is normal. We're looking to see that the thorax is symmetrical with no deformities. She doesn't have a barrel chest. Her respiratory effort and movement is even and symmetrical, which is what we're looking for. Her respiratory rate and rhythm is regular, both anterior and posterior. Her a little bit. She doesn't have any muscle retraction. She is in no respiratory distress, no use of accessory muscles, no diaphragmatic breathing or shallow breaths. Her respirations are about 16 respirations per minute, and her AP diameter is 1 to 2. Next, we're going to go ahead and inspect the lips. So we're looking for her lips to be pink and moist. You want to look for any blueness or paleness. If there was, that would indicate cyanosis. We're also going to assess for her fingers and nails. So go ahead if I can see your fingers and nails in that. So we're looking for any clubbing or cyanosis in her fingers. We're going to check for cap refills. Since she does have red nail polish, it's hard for us to assess that, but we're going to push against her finger right here and look at that cap refill, which is less than 3 seconds. After assessing that, we're going to move on to palpation. For the purpose of this video, the patient is going to keep their clothes on, but for a real patient, we would palpate directly onto their skin. I'm going to palpate both the anterior and posterior, and I'm looking for any tenderness, crepitus, or masses that can be felt. So we'll start from the front. We're going to go ahead and palpate. Any tenderness in it?
No.
Awesome. Any tenderness?
Mm-mm.
Perfect. I'm going to do the same thing from the back. So we're going to just go ahead and palpate. Any tenderness?
No.
Awesome. Perfect. Once we're done palpating, we're going to do a respiratory excursion. So we're going to check this both anterior and posteriorly as well. It's to check the symmetry of lung expansion. I'm going to place my thumb on each costal margin and hands along the lateral rib cage, which is on the 10th rib. I'm going to bunch up the skin like this, and then I'm going to have the patient inhale and exhale. So go ahead and take a deep breath. Perfect. And exhale. One more time. Perfect. So we see the divergence of the thumbs and thorax expand, and then we're going to do the same thing in the back. And we want it to be, we want to see the range and symmetry. We want it to be symmetrical on both our hands. The same thing. We're going to palpate for the 10th rib. We're going to put our hand like this and go ahead and take a deep breath in and out. And exhale, breath in. So you can see my hands, my thumbs move together and apart. Perfect. After this, we're going to move to assess tactile fremitus. This is another one. We're also going to do both anteriorly and posteriorly. You can use the palm of your hands, but I'll be using the ulnar side of my hands. I'm going to be placing my hands on her chest and having her say 99 and to assess whether the vibrations are equal on both sides. Annette, every time you feel my hands on your chest, please say 99.
99. 99. 99. 99.
Perfect. Then we do the same thing posteriorly. So every time you feel my hands again, please say 99.
99. 99. 99. 99. 99.
Perfect. You can turn back around. So after that, I'm going to go ahead and check for costochondral tenderness. So we're just going to palpate the chest, and if she had any inflammation in the costochondral joint, it would show as chest pain. So any tenderness or pain?
No.
Awesome. Perfect. So after that, we're going to move on to percussion. When we percuss, we want to make sure we move side to side in a ladder position. We're also going to be percussing anteriorly and posteriorly. So we're going to percuss in the lung fields in between the intercostal spaces. We're going to strike the dip joint of the non-dominant hand with our dominant hand. So we're going to go ahead and feel for the intercostal space. All right, and then just using my dominant hand, move side to side. See if you can, perfect. Perfect, we're gonna do the same thing in the back. So we're gonna look for her intercostal space right here, and then perfect. Once we're done percussing the anterior and the posterior, we're gonna look for diaphragmatic excursion. I'm gonna be doing it on one side, but on your patient you would do both sides. For this video, we'll just be doing one side. I'm gonna percuss to check the levels of the diaphragm, and then we're gonna measure the excursion. So I'm gonna go ahead and percuss to see where I hear for dullness. So we're gonna go ahead and put my hand on this side. All right, that's where I hear dullness, and then we're gonna have Annette, if you can take a deep breath and hold it for me. I'll feel for resonance. That's about right here. Go ahead and relax. So then on a patient, we would mark those two areas and measure it to see how long it is. It should be anywhere from 3 to 5.5 centimeters. That's normal. So we want to measure bilaterally and make sure that they're equal. After that, we're going to go ahead and auscultate. Just like we percuss, we're going to do it from a side to side and lateral fashion. We're going to auscultate both the anterior and the posterior. So we can start with the posterior since I'm already back here. And that every time you feel my stethoscope on your back, please take a deep breath for me, okay? So we're gonna, perfect. Perfect, and then now I'm going to listen anteriorly. So again, every time you feel my stethoscope on your chest, go ahead and take a deep breath. Lastly, right here. Perfect. So breath sounds are clear in all areas of the upper and lower lung fields and laterally on each side. Breath sounds are vesicular. There's no adventitious sounds such as wheezing, crackles, or rhonchi. So that's within normal limits. Lastly, we're going to do our specialty test, which is bronchophony. So every time my stethoscope touches her back, she's going to say 99. I should be listening to, it should be muffled and indistinct. If I do hear the 99 clearly, then that means that there is consolidation. So I'm going to go ahead and move posteriorly. We're going to move your hair, Annette. Every time you feel my stethoscope on your back, go ahead and please say 99 for me, okay? All right, here we go.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Perfect. That completes my respiratory assessment. Do you have any questions for me, Annette?
No.
Perfect, thank you.